My first patient that I took care of is from Craig, just a couple of miles down the road. And his big problem, he still works in the mine out there, but his big problem was he couldn't lift his grandkids, and he just really had a hard time working. And a week after the surgery, he was, all smiles, grinning ear to ear when he came to see me. Pain was totally gone. He was able to pick up his grandkids. They had an article in the paper about him with that, and it was just really cool to see.
We're back with another episode of the Spine Pod, and this time you find us in Steamboat Springs, Colorado.
Steamboat Springs, this is a really special one. We got to sit down with Dr. Alex Sielatycki in Steamboat Springs here at his practice at SOSI, and this was really important, I think, for us. We've been waiting for this one for a long time just because of the relationship we've been able to build with Alex over time, what we've seen him do, and kind of how we've come to get to know him throughout the last 3 to 5 years.
Yeah, absolutely. And also, I think when we started this podcast, he's the exact type of guest that we were looking for. Completely committed to motion preservation, the idea of a motion surgery center. He just has so much knowledge and excitement around this topic. So it's really fun to talk to him about it.
It's absolutely, you're spot on. I think it's fascinating too to see a guy like him who trained under complex deformity guys, right? Yeah. When he was out at Columbia, and he had a little bit of work with motion preservation with Dr. Rue, but he, based on the outcomes that he saw and the data that he saw, he chose a different path. Mm-hmm. And he's now carrying the flag forward for motion preservation across the board. And I think it's fascinating when you see someone that kind of switches lanes like that to push something forward.
I agree. And I think it really means something when someone is willing to kind of step out on their own, or step out where, there's very few who are willing to do that, and try something new and be really committed to it. And that's why I'm really excited, mostly for patients, for this episode, because this is an opportunity to hear directly from someone who is committed to motion preservation, sees that fusion is not good enough as a standard of care, and is really out there doing a breadth of motion preservation options. And so great knowledge to hear from Dr. Sielatycki.
He's only 6 years into practice, and he's already established himself as a leader in motion preservation.
Incredible, yeah.
And not just motion preservation, but across the spine community. Mm-hmm. We've seen him speaking at conferences. We've seen plenty of his publications. We've seen everything that he pushes forward on LinkedIn.
Yep.
I mean, the work that he's done in clinical education and clinical training has been absolutely astounding. And I think it's really special too, because it kind of takes you back to his roots and some of the training he did with one of his mentors, Dr. Clint Devon, who actually started SOSI. And now Alex has picked up that torch and is absolutely carrying it forward. And I think it's so special to watch that kind of unfold. And he's 6 years in. He's got another 10, 20, 30 years down the road, and it's going to be exciting to see what he does.
Yeah, this is a career I definitely want to watch, and I think it's going to make a huge impact on the standard of care, and just what he's going to do for patients it's already life-changing what he's been able to do for so many patients, sticking to his guns and saying, I'm going to do motion preservation, but the impact he's going to make on the industry and the standard of care overall is really exciting.
And he's already doing that.
Yeah.
He's been out here at SOSI for 2 years, and he's getting patients that are traveling from all over the U.S.
Yeah.
It's truly impressive. And as he continues to build himself as this motion preservation surgeon, which he's already known for, he's going to get more and more of that. His practice is going to get bigger and bigger. And it pushes it out for everyone, right?
Yep.
We're seeing more surgeons that are starting to adopt this idea of motion preservation and integrate it into their practice. I mean, 85% of his cases are motion preservation cases.
Yep.
And soon down the road, it's going to be 100%. He will be a motion exclusive practice because he'll be able to do it, right? Mm-hmm. With the emergence of new technologies. And I think that's really exciting.
It's really exciting. So I think we should let them get into it.
Let's jump right in.
Awesome. So enjoy this episode with Dr. Alex Sielatycki.
Dr. Sielatycki, thanks for taking the time for sitting down with us today.
Yeah, absolutely. Thank you.
Yeah.
I feel like we're becoming regulars here.
Spent a couple of days here, I know.
Yeah.
It's been great.
Yeah, we've been really, really lucky to work with you and get to know you over the past few years. I'm not sure if there's anybody else that we sit down with where I know their parents. I ran into Jamie and Laura the other day when I was on a run. I thought that was pretty funny.
Yeah.
In a 3-spine hat. But truthfully, I mean, we resonate with so much of what you're doing out here, what you believe in, the practice that you've built out here. So we're really excited to sit down with you and finally have this conversation. I think we want to bring it back to the start and give viewers just a little bit of idea of what brought you to medicine in the first place and a little bit of your background.
Yeah, so my path into medicine is not an unusual one. I was a young athlete in high school and was destined for the NBA. I was going to be a professional basketball player. I was convinced.
You're so tall, so of course.
But yeah, some shortcomings came up, including my height and skill on the basketball court. So I had to figure out something else to do. And actually I had an ankle injury in high school and saw an orthopedic surgeon, and I always liked science and biology. And so I sort of gravitated towards the sciences anyway. Then I saw the orthopedic surgeon for my ankle, did not need surgery, fortunately, but thought, hey, that's a kind of a cool job. Why don't I look into that? So went off to college and here we are now.
So as an econ and finance major, you decided you didn't want to go down that path? Or
yeah, I went to college thinking medical school. And then in my early year in college, I thought, well, I had a bit of a panic moment at a young age. Not really a panic, but just, maybe I don't want to do this. Maybe there's something else besides medicine, because I had been on that one-track mind for a couple of years. So I took some econ classes just as part of a general requirement and really liked it, found it interesting and gravitated towards that and decided, all right, I'm not sure what I'm going to do. Economics was very interesting. The finance piece fit really closely with that. So I kept doing all the medicine prerequisites and finished out the economics major and ultimately decided to continue on into medical school. But that was the path I took.
Little transition.
Yeah.
Yeah, but I think it's a great, background to have when you are going to start your own private practice or be a part of a practice where you have that mindset that can be really important, because you're essentially an entrepreneur when you're, a surgeon.
In a lot of ways, you're running a business in many ways. An economics undergrad major, I would not say qualifies you to really run a business. It's more kind of the school of hard knocks and getting out there and doing it and learning on the job and learning from people who've done it before. The thing that I believe it did give me was the ability to really think critically about problems, whether that's in medicine or otherwise. And that's what I liked about economics. It's a very practical, pragmatic way of thinking about problems and thinking about solutions to those problems. So.
Well, you've certainly gone out and created it now, and we'll get into that later. So you grew up out here, out west, and so you went to Utah State, and then you moved over to Penn State. Can you talk a little bit through your education journey? I think it's important to talk about, some of the training aspects too, and kind of how your career path diverts and what you specialize in moving down the road.
Sure. So went off to medical school ultimately, and pretty early was confident that I wanted to do surgery. That was confirmed early in medical school as well when we did the anatomy lab and the dissections, and I really took to that, enjoyed learning the anatomy and understanding the mechanics of the human body and the physiology of all that. So that was pretty clear to me early on that I wanted to do something in the surgical realm. Orthopedics seemed natural because of, again, my initial interest in medicine was in orthopedics. I did have a bit of time where I thought carefully and hard about cardiothoracic surgery, specifically pediatric cardiothoracic surgery. I spent some time with a peds heart surgeon at Penn State, got to scrub cases with him, and it was really incredible work that he was doing and really fascinating work. And I thought pretty seriously about that for a while, but ultimately came back to orthopedics. And a lot of that is, I think many people in medicine will tell you, it's driven a lot by your mentors and who you gravitate towards. And so the orthopedic surgeons that I worked with and learned under were great people to learn from and work with. They seemed to really enjoy their work. So that naturally was something that I leaned towards. So then I was at Penn State for medical school. I went off to Vanderbilt, did a rotating visiting internship there as a medical student as a fourth year. It's like a month-long tryout as a resident, and really, really had a great time there. And that was my first experience in spine surgery, really. specifically. I had done a lot of orthopedics as a medical student. At Penn State, they didn't really have the med students in the spine OR very much. But at Vanderbilt, I was on the service of Clint Devon, my mentor there, for a month. So I spent a month doing spine with him, and him, the late, great Clint Devon. He was just fantastic to work with. Really, truly a mentor in every sense of the word. Great teacher, great person, and it was just magnetic to be around him. So very naturally, started gravitating towards spine. Then ended up in residency at Vanderbilt. Very grateful for that. That was my top choice. Very happy to go there. It was a great program. And, early on there, did a lot of, all the orthopedic specialties, but still early on gravitated towards spine, working with Clint again, really became a strong interest for me. And it was evident pretty early on that that's the path that I wanted to take. And not only because of him, but I enjoyed the surgeries. I enjoyed the pathology. I enjoyed the fact that there's just so much we don't fully understand in the spine world. There's a ton of room for improvement, which is kind of what we're talking about today, motion surgery, which is still pretty much in its infancy here in the U.S. It's been, a little bit further down the road in some other countries, but there's still a long way to go in improving on the craft. And so that was interesting to me.
Obviously, we have, very close ties with Clint Devon, and we've heard, he's a big name in the spine community alone, and we have worked with so many surgeons that say the same exact thing about him, how incredible he was as a teacher and as a mentor, and even outside of spine, just being that figure and that presence to help push people along. And I want to go back and talk about that. But you finished up at Vanderbilt, you went up to Columbia for your fellowship, and then you started practice down in Chattanooga, which is kind of where you got integrated with Dr. Scott Hodges, who we know very well. Can you talk a little bit about your initial practice, leaving training, and what that was like, what you guys were doing?
So yeah, not to gloss over my year in New York, that was fantastic training. I was incredibly blessed to train with some of the top surgeons around, Dr. Lenke with deformity, Dr. Lehman, and Dr. Rue. I learned a ton from those guys, and I'm incredibly grateful for my experience there. The path I took after that, a little bit less traditional for the typical Lenke fellow. Didn't do an academic practice. I thought long and hard about it, and almost came to that. But ultimately, the opportunity in Chattanooga was appealing for a number of reasons, not the least of which was it was a busy practice in a busy market, and it was a chance to get out and really get my feet wet and cut my teeth on surgery and really do a lot of surgery and get good at it as quickly as I could, because all the training we do, and I would argue, some of the best training in terms of my experience at Vanderbilt and at Columbia, you still have that cushion or that fallback of your mentors are there. Yes, I'm being pushed along and I'm doing the surgeries, but you're not really on your own until you're on your own. And there's still an immense learning curve the first year to two in practice. And I think any surgeon will tell you that their first 1 to 2 years in practice is a big, steep learning curve to not only become more efficient in the OR, but to lower complication rates, to get really improved outcomes. And so for me, early in my career, that job was an opportunity to do that. And Chattanooga was also a great town, great place to live. My wife and I both really liked that as well. And so it seemed like a good fit. And I'm incredibly happy that we did that, because that is what got me involved with Dr. Hodges, and really was my initial spark of my interest in motion preservation. I did do cervical disc replacements with Dr. Rue at Columbia and learned the technique there, and he does a masterful job of that. We still did a lot of fusions, and so it was one of the tools in the armamentarium there, but it wasn't an emphasis or a focus. Clearly, it's a big deformity specialty or deformity fellowship with Dr. Lenke and Dr. Lehman, and so I did a lot of big scoliosis cases, which is a fantastic learning as well. But the motion preservation side of things really didn't kick into high gear until I was in Chattanooga with Dr. Hodges and started learning about what he was doing.
So you had this initial, motion preservation out at Columbia, and then you kind of continued that in Chattanooga. Spent about 3.5 years in Chattanooga, and that's kind of where we get to the story that we are now. The story of Clint Devon and his unfortunate past after starting up SOSI. What was it that made you take the leap? Like you said, Chattanooga is very busy. You guys like the city, but What was it that made you take the leap to come out here to SOSI and essentially start anew after starting in Chattanooga?
Yeah, there was a number of factors. It had been something that Clint and I had discussed for a while. Even back when I was a resident, he talked to me about the idea to come out to Colorado. He's from Wyoming, just a couple hours away. And he had the idea to come and build a spine practice here in this community and to have some outreach into Wyoming. And so he did that. And all along, he had the thought of, hey, when this gets busy enough and I need a partner, I may ask you to come. And so we had kept that in mind over the years. And it was always something we talked about. It wasn't anything that any official moves had been made on, but it was in the framework and in the mindset. And then he was in the plane crash and passed tragically. And he had already spoken to the group here a little bit about eventually bringing me on. And so then there was sort of a natural transition where he had built a very busy practice here and left an immediate void that needed to be filled. And so the opportunity was presented to me to come and fill that. And so it had been something we'd been thinking about for a while. I personally have always loved the mountains. I grew up in Utah in the mountains, and I always loved skiing and being outside and hiking. And so that was an appeal to me. Having now 4 kids, I had 3 at the time, but it seemed like a great place to raise kids with a lot of outdoor activities, a very active lifestyle, which was appealing to me as well. And then as my involvement increased with motion surgery and with Modus and all of this, I have kind of developed this idea and this goal of having a motion-focused, motion-centric spine practice. And there are a couple of other surgeons doing that, and that's been appealing to me, and it makes a lot of sense. And Steamboat seemed like a really great environment for that. It's a very active community. It's a beautiful place to be. There's a lot of people here that wish to remain active and ski and hike and bike. And there's a lot of also local ranchers in Wyoming area and around here that they want to be active and working hard on their ranch. And a fusion just isn't really in the cards for people like that if they can avoid it. So I think that fit well, the local market fit well with motion preservation. It fit well with what I think was going to be good for my family, as well as a nice place to live. So we said, all right, here we go. And here we are.
Yeah, I would love to live here. It's not a bad place to land. I'd love to hear your thoughts a little bit more, like diving a little bit deeper on this idea of, you got into practice and you were really open to the idea of motion. Can you kind of give us an insight into your mind at that time of like how you were perceiving motion preservation, the options that were available compared to fusion, which is what everyone was doing? As a, young in your career, as you got started, how did you feel about it, and what was that path like?
Well, I will admit I didn't come out of fellowship thinking I'm going to go do motion surgery. I trained with big time fusion surgeons with deformity and with good reason. That's what they do for those problems. That's still what's needed. But I didn't really have that in my training, not that focus in my training. It was more, I would say, a classic spine surgery training. And I didn't come out necessarily thinking I need to change this. But it wasn't long into practice, seeing patients on my own, seeing not just my own fusions, but other fusions that had been done in not the too distant past. So a year, 2 years before, now people are back and they're miserable. And as a practicing surgeon, I think you get a little bit of a different feel and flavor for patients when they're sitting in your office and you're now in charge of helping them. When you're a resident in training, you look at the x-rays, look at the images, and you read the papers and you read the textbooks and you learn from your mentors and you think about, okay, what's the recommended technique for this? But you're a degree or two removed from just looking at a person who's in front of you who's suffering. And you hear their story about how they had this fusion and now they're worse than they ever were, or it helped for a year and now they're back, and or they've had multiple. You've seen the train wrecks of 3, 4, 5, 6 fusion surgeries, and now they're addicted to pain medicine and they can't work anymore and their life is over. And so you see that and how miserably it can affect people's lives, and you think, man, there's got to be something better than what we're doing. And on top of that, I had Dr. Hodges poking me in the side saying, hey, look at this, and showing me some of the things that were going on with Modus. And my initial reaction to that, as I think most surgeons are, is skepticism and saying, this thing is bound to fail. It's going to be unstable. And obviously was skeptical about that, but kept talking with Hodges about it. And he showed me some cases that they had done in the preclinical data. And I saw the patients coming back myself and looked at them walking down the hall and looked at their x-rays and looked at, how amazingly well they were doing compared to
your fusions.
The fusions.
Yeah.
And, not every fusion does badly. That many of them do very well. But this just seemed like a next level of good result for people with the potential of not incurring adjacent level disease down the road where you're going to have multiple surgeries. And so right away, that seemed like at least something looking into. And the further I dug and looked into it and read the papers and looked at the studies and then did the cases with Hodges and learned the technique, and now having done the cases myself and seeing the results, the more of a believer I became.
And you didn't just read the studies, you've published studies on this. And so I actually want to take a step back because that's somewhere too where you've committed to some of these concepts, right? And these ideas. Can you talk about, when we take a step back, why motion is important from a global perspective, right? You've published on moving through planes of motion, sit, stand, slump sit. You've talked about the force loading of slump sitting and radiographs and looking at them. Can you talk about why that's important and having motion?
Well, I think fundamentally it's how our bodies were designed. So we were designed with mobile joints, hips, knees, shoulders, hands, and spines. Spines are not fixed, rigid devices or organs. And so fusing a spine in a rigid position is just completely non-physiologic, and it's not the way it was designed. And so as a result of that, you're going to get a lot of negative downstream effects, adjacent segment disease, not only the level above, but the levels below. And many surgeons don't talk much about the pelvis and the hips as a sort of an adjacent segment. A big lumbopelvic fusion, now the pelvis is locked in place and those hips are taking a beating every time you sit and stand. And people with, hip replacements have been shown to have, more dislocations after spinal fusions. We know that. And so there's clearly more strain on that system as well. So if you're thinking about what are the overarching goals of surgery, give people relief of pain, number one, but also to restore function, especially in orthopedics. That's kind of an emphasis of orthopedic surgery, restore people back to function and to their mobility in daily life. If you want to have somebody not have pain, just lock their entire spine together in one position, yeah, you can do a really good decompression and lock them together. Their pain may not be all that great. They're not able to move around much. They can't bend and twist and do the things that they want to do. And so, just thinking about what are the goals of surgery, improving pain, restoring function. Well, function is motion. It's what it's designed to do. So if we have the ability to decompress a nerve, get rid of anatomic or structural pathology, but still maintain the mobility that's intended to be there from the beginning, that has to be superior to just locking it in one position.
So understanding that, that makes total sense, right? So then Modus comes in to the picture. Can you explain what Modus is, how it compares to the standard of care right now? What's different about Modus and what makes you excited about it?
Yeah, I think the biggest appeal of Modus is the versatility or the widespread applicability of it. So there's a lot broader range of indications for Modus that previously wasn't available for lumbar patients. So we have anterior disc replacements, which clearly do very well for degenerative disc disease and are superior to fusion. When you look at the data for degenerative disc disease, if you look at fusion for that versus anterior disc, it's a clear winner, both in terms of results and reoperation rates and longevity. It has a limit because many patients don't only have isolated disc disease, they have severe facet disease. And with severe facet disease comes severe stenosis, central and recessed stenosis specifically. And that just is difficult to manage with an anterior disc. So a good number, and I would say the majority of patients who see us for low back complaints are in that second category of they have some disc degeneration, but they also have facet disease and they have some degree of stenosis. And it's not as common to see an isolated anterior disc pathology. Now, some practices probably see that more if they've tailored their practice to that. But I would say in the typical general spine practice, you're just not seeing a huge percentage of people that are good bone quality, healthy facets, and isolated disc disease that's clearly symptomatic and would benefit. So Modus is nice because it allows us to really broaden the indications for motion preservation. You can do a posterior approach, and we can avoid the pitfalls of an anterior approach, which we can get into, but posterior approach allows you to do a complete posterior decompression, complete laminectomy, facet removal, and disc removal, and treat all three parts of the motion segment. So they call it a total joint replacement. You're replacing the disc and the two facets functionally. And I think that that's really kind of the workhorse of lumbar surgery. In the cervical spine, and Clint used to say this, in the cervical spine, you really needed to be able to do an anterior approach because that's where you're going to get the best decompression in a lot of cases. In the lumbar spine, you have to be able to do a good posterior approach because there are many cases where you just have to do a good direct decompression and do a laminectomy and take the facets off. And until Modus, once you do those things, you've had to do fusion. If you have to take the facets and do a big wide decompression, you're obligated to fuse to prevent instability. But Modus is the first implant that allows us to do that reconstruction and keep things mobile. So for me, that's why it's such a big deal and is exciting, frankly, to see it coming around. And I've been happy to be a part of that study.
So one of the things I do want you to talk about is you brought up the word hesitations. And the first time I saw this, that was what came to my mind was hesitations is because it's a different approach, right? It is something that we have not seen before. And, you talk about this concept too of stability. And one of my favorite quotes from you is you talk about destabilizing to restabilize. Can you talk about how you got over that hurdle or that initial hesitation for a new device, which isn't just a Modus question, but for any device? But how did you get over that hesitation?
So, the initial hesitation is you look at an implant where you've taken away the entire posterior elements and the disc, and you have this implant in there that's going to allow things to move. And the classic training in me thinks that's not going to hold together, that's going to fall apart. Really, the thing that got me over that hesitation was just seeing the results, seeing the data. So looked at the data that Dr. Pat Warden did in Chicago, looked at all the biomechanics testing. I actually went to his lab and did some of these in cadavers and looked at him on his stress follower load model and watched him stress the spines that we had put in there, and they didn't fall apart up to these, huge forces. And then seeing them in patients and seeing how they're doing, not just 6 weeks out, but 6 months, 1 year, 2 year, now 5-year data on some of the early pilot patients and even the initial patients being done in the early 2000s, 15 plus years of follow-up. It's small end, but still those patients that are still doing very well. I mean, the proof is in the pudding. It's right there. There's people that are doing really well with it, and they're not unstable. And I got to digging a lot more into the biomechanics of why that is, and understanding that, and the distribution of forces being more compressive as you activate lumbar extensor muscles, and it's not a direct 1-to-1 shear compression ratio like my mind thought it was, and the implant takes advantage of that, and it works.
You're a believer in motion preservation devices across the board, right? You do a ton of discs, both cervical and lumbar. You've done a lot of Modus cases. Do you see a difference, whether it's immediately post-operatively or long-term? Can you talk about differences between those patients and whatever you'd call a fixation patient or a fusion patient? Are you seeing differences in your patient outcomes just, initially?
Absolutely, I am. I would say apples and oranges when you're talking about lumbar and cervical. So cervical patients, cervical disc, I would say definitely anecdotally as well as in the data, people's recovery is quicker with cervical disc versus fusion. Their return to activity, their return to sport or work is lower. And so we see an early benefit to that. And then longer term, lower rates of reoperation for adjacent segment disease and clinical outcomes that are at least as good, if not better, in many studies. So that's been pretty evident. In the lumbar spine, specifically if you're looking at Modus versus a fusion, there are many cases where I think the first 3 months, there's not a huge difference. You've done a wide decompression. You've gotten the neural elements opened up, which is the primary pain generator in most cases, and all the cases really. I mean, you're doing these cases for stenosis or some level of it. So once you relieve that, people feel better. Really where Modus seems to have sailed is after that 3-month point, when people just continue on the upward trajectory of pain improvement and functional improvement, whereas the fusion patients kind of seem to level off. They did well, they got their initial relief, and now at 3 months, they're ticking along here, and slowly over time, their pain starts to creep back up with adjacent segment problems. I will say there have been a couple of early home runs with Modus, which I didn't see as much of with fusion. So patients that are, almost right out of the gate, by a week off of all pain medicines, by a couple of days off of all pain medicines, doing great, and you have to kind of hold them back so that you don't, overstress it. So there was that element. There was another it's a spectrum of patients, though. There was some that I would say probably struggled longer than a fusion patient might. And Hodges and I have talked a lot about why that is. And, in some of these patients, we get the early decompression, we get the stabilization with Modus, and they do well for 2 or 3 months. And then they start moving and they start doing more. And one thing that we believe is happening is that now that they have their initial pathologic segment reconstructed, they're starting to move more. Their adjacent levels, which had been undergoing more maybe compensatory stiffness, are starting to mobilize. And so previously relatively immobile facet joints with fibrotic capsules are now starting to move, and their back pain can start to creep up. And we found that you push them through that with therapy and stretching and keeping things active, and then that improves ultimately. So sometimes it's a little bit of a longer recovery, and it does take some more patience with the patients as the surgeon to help them through that and say, look, this is okay. We keep moving, we keep going, and ultimately they do well.
These are patients you're talking about that you did in a US FDA IDE trial. You do have some patients, I think, that are about a year out from.
Yeah, coming up close to 2 years.
2 years for some of yours.
My first patient that I took care of is from Craig, just a couple of miles down the road. And his big problem, he still works in the mine out there, but his big problem was he couldn't lift his grandkids, and he just really had a hard time working. And a week after the surgery, he was, all smiles, grinning ear to ear when he came to see me. Pain was totally gone. He was able to pick up his grandkids. They had an article in the paper about him with that, and it was just really cool to see. And there's been other patients on the other end of the spectrum. There's one gentleman who I took care of here who was previously a big mountain competitive skier, and had to give that up because he had a spondy, L5S1 lytic spondy, and just his back was limiting him too much. And we did the Modus for him. He's, I think he's over a year now, and he's looking now. He asked my permission if it's okay for him to train to get back into competitive big mountain skiing, and I said, sure. Yeah,
That's wild.
So he's going to do it. So that's been pretty cool to see. Now, I think this season is going to be his, re-inauguration back into big mountain skiing. So we'll see how he does. But so far, so good.
He's going to really test it, huh?
Yeah. He's gonna, big cliffs and backflips and all. Yeah. He's going to stress it. So if it holds stable with that, we know it's stable.
So we're still kind of in that, waiting stage, and hopefully in the near future, we will have that, lumbar total joint replacement that we don't have right now on the market. I think, we're right there. But I want to talk globally about motion preservation as we talk about, cervical discs. And now we do have a facet replacement with TOPS on the market, and hopefully soon a lumbar total joint replacement. Can you talk about how motion preservation as a whole changes the continuum of care? Because I think that's one thing that we've seen change as well in what kind of cases we're seeing and when people are going to actually get treatment.
Yeah. So I think the availability of motion preservation does, for me, changes the algorithm, because up to that point of having motion options, most patients have been told by either their friends, family, or their surgeons, wait as long as you can. Don't get a fusion unless you're miserable. And I think that's appropriate, because fusion is not great unless you're miserable. And then it can do fine. Yeah. But what happens as a result of that is people put off surgery. They put off fixing the structural problems that they have, which then leads to some natural propagation of natural adjacent segment disease. So you have a dynamic spondy at L4, L5. The disc collapses, gets stiff, doesn't move well. The other segments can start to take a beating as a result of that. And so, are we seeing some of the late stage degeneration as a result of avoiding surgery for your whole life? It will obviously take a long time to prove this out, but I believe that, if we're able to intervene sooner with a non-fusion option, could we potentially be protecting some of the other levels from that late stage degeneration? It's going to take, honestly, decades to be able to prove that. And even then, it's difficult to prove that notion entirely. But I think it certainly makes sense that restoring normal motion and function to a level has got to be helpful, not just for that specific pathology, but for potentially protecting the others. And so that having that availability, I think, will allow us to see what happens over the long run. And also, patients are less hesitant about undergoing an operation when you talk about a disc replacement or a motion preservation option rather than fusion. Many patients come to see me and you start to mention surgery and you can see the look in their face like, I didn't want to talk about surgery, but then you talk about a motion preserving option, it's not fusion. And they go, oh, okay, well, that's interesting. Tell me more about that. And they're more open to the idea.
It's so interesting. Actually, it was scrolling on, I think it was LinkedIn. I can't remember, somewhere earlier this week. And someone had a shirt on that said, I survived back surgery. And I'm like, how often do you have like something where you like, I survived back surgery like that? But that's really how patients feel of like, I don't want to do this. And it's really interesting that you see a shift in perspective for a patient that's looking for motion versus they just innately understand that they don't want a fusion.
Yeah, I definitely saw a lot of hope and optimism in the eyes of the patients that were enrolling in the trial. And I see that for cervical discs too. When you talk about we're not doing fusion here, I think it's just much more palatable for them to think about having that as an operation and thinking I'm not going to lose mobility, I'm not going to put stresses on my adjacent segments and be doomed necessarily to multiple surgeries. So that's a daunting thing to think about if you don't have another option.
I think it's a fascinating concept too when we talk about essentially just moving. You're treating the same patient, right? You're just treating them at a different point in time. So you're moving what would be a complex deformity case into hopefully a degenerative case, right? Which you treat totally different, right? Like that is the hope down the road. It's funny when you think about it. It's like if you got a flat on your tire, you wouldn't just like roll on it forever because it's going to ruin the rest of the car over time. It's kind of the same as your body, right? We have kind of have that little bit.
That's a great analogy.
Yeah, it's kind of the same sort of situation.
You've got a flat tire, fix it before worse problems come about.
That's exactly right. So do you have patients that are now coming in asking for these? Like, you've been in practice 6 years now, right? So still early on in your career, but you've seen a shift. Have you seen patients that are now coming in, asking or requesting certain technologies or certain procedures?
Oh, absolutely. I mean, for sure with cervical discs, people have been told elsewhere they need fusion and they come to me asking for an alternative and seeing if that's an option. And with Modus, I've seen that. It's still in the investigational phase, as you mentioned, now in data collection. So we're not, it's not something that's being promoted because it's not really available. But I still, even to this day, get patients coming and asking about it, requesting it. They've found it online. They did a lot of research on their own and they think, hey, this thing looks like a great option for me. And so I hear that very regularly, people asking for that. So people are savvy, they're well-researched, and they, the prospect of surgery on your back is a big one. And so many people get online and they talk to friends and family and they find out quickly that there are other options and they seek those out.
Can you talk a little bit too about, you brought up this concept earlier about how we used to in spine just treat for pain reduction. And I think that's an important delineation because now we're treating for different elements, right? Essentially, you were treating for pain reduction and removing, neurologic deficit were the two things you were trying to treat for. Now we're looking at functional outcomes, right? What can you do after surgery? Even, time of operation, return to work is a huge one. Can you talk about how that dynamic is changing too and just what we're measuring in these patients' outcomes?
Yeah. So historically, like you said, pain reduction, neurologic improvement or removal of neurologic compression is the main goal, and that's still, I would say, one of the overarching goals of what we do. But function is a huge part of what people want, and it's I think a lot been driven by the focus on patient-reported outcomes, and that's come into the forefront appropriately so because what we're doing is treating patients, and so what we should be offering is treatment that matters to patients. And what matters to patients but reducing pain and improving their function and improving their ability to do what they want to do and live the life they want to live, whether that's returning to work or athletic activities or otherwise. That is what people want. And so as surgeons, I think we're obligated to do what we can to provide that. And it serves our patients and it serves us well because we then have satisfied patients. We have satisfied clients that send us their friends and they're happy with us, and which is very rewarding on the treatment side to see people that do well and they're happy and they're back to doing what they want. So, the goals are aligned on both sides, and they should be aligned on both sides. And so, that's something that we've paid a lot more attention to. There's been some great work done by a lot of really big time thought leaders on how do we really measure success with surgery, and those factors play a huge role, not just from the patient satisfaction standpoint, but also from an economics perspective, getting people back to work and back to making their own income. And all of that is huge.
When you talk about what patients are looking for too, those functional outcomes are so important. We're starting to see elite athletes that are moving towards that, right? And you talked about people that you have. I mean, you get farmers and people that are doing labor work and, skiers. We're seeing it. There are NHL players now that are going to get these things and opting away from, older alternatives because they're like, this isn't the end of my career. This is the start of the next phase of my career, right? Which I think is really, really fascinating. I want to talk about something too. We've talked about this in the past. Your approach to surgery in general, right? One of the concepts is, you can start small and you can always build to putting an implant in. But can you talk a little bit about, having a simple decompression, which is still a motion preserving surgery, and then when you kind of convert and say it's time for implant?
I sort of think about it as it's kind of a spectrum of disease in the lumbar spine specifically. That's on sort of a continuum. So at the early end, you may have some, say, isolated back pain, some disc degeneration, no neurologic symptoms, and some dysfunction because of stiffness in a segment that then translates into other segments. That's more of a functional problem, I would say, than a true anatomic or structural problem. And that's best treated with non-surgical measures, physical therapy, getting the pelvis moving again, getting the hamstrings stretched out, getting the core strong, and restoring function through physical therapy. And that's at the early end of the spectrum, and that is absolutely a huge part of spine care and needs to be. There are conditions that progress further down the spectrum where now there is more of a structural problem with a neurologic compression, and a nerve root is compressed by, say, a herniated disc. And it's not going away. You've done some injections and it's just not improving. And there still is that pebble sitting on the nerve causing a severe radiculopathy. Well, then a minimally invasive discectomy, be that endoscopic or tubular through a microscope, is a great option. You're going in and removing the offending agent with minimal disruption of the muscles, minimal disruption of the surrounding tissues, and it's still a motion-preserving surgery. You're not fusing that segment. Further down the spectrum, there's more advanced facet disease, severe stenosis, instability or microinstability, and that's where we can get into the realm of minimally invasive decompressions, laminotomies with over-the-top decompressions, which I do a lot of that work as well. But there are cases that are too far gone. Their disease is too far progressed. They have too severe facet disease, too much of a spondy, too much of a slip, or they may have already had a couple of these other less invasive operations. So you have somebody who's had 2 or 3 laminectomies or laminotomies at the L4, L5 level. Now it's slipped forward to a grade 1 spondylolisthesis with bilateral foraminal disease, and the disc has collapsed and everything is just falling apart there. It's a much more advanced degeneration, and it requires a more advanced reconstruction, not just a simple cleanup, but actually reconstructing the segment, restoring disc height, restoring motion. And so in many cases, things like Modus are not only, in my mind, motion preserving, but they can be motion restoring. By restoring disc height, and the same as in the cervical spine, you have a collapsed disc, you open it up, you put a disc in, you do proper soft tissue releases, and that level now moves again where it wasn't moving before. And so it even moves beyond just motion preservation to motion restoration.
We love that you're a motion preservation guy. We love that you're focused on it. I think one of the things that we love even more than that is that you push, the boundaries and and maybe boundaries isn't the right word, but
you're pioneering.
You're pioneering the field of motion preservation because it doesn't get pushed by insurance, right? Insurance isn't coming to you and say, you should do a 3-level disc replacement, right?
They push the opposite way,
exactly
actually.
Right.
They push back and tell me I can't do it. And there's a lot of frustrations I have with that, where I see a patient with 3-level cervical disease that is a great candidate for 3-level arthroplasty, and we cannot get their insurance to authorize it because it's off-label use.
So that's exactly what I want to talk about, right? You don't have insurance coming to you saying, oh, you should push this treatment. You're deciding, hey, I did a 1-level and that worked. Okay, we'll do a 2-level. And now we have reimbursement for 2-level, but I've seen 3 and 4-level cases of you. What kind of decision-making, or how are you going through that process of deciphering when, I'm going to do a 3-level, I'm going to do a 4-level, or what are you seeing in patients that's making you continue to push that bound and provide that care?
Well, clearly with 1 and 2-level disease, we have seen, and the literature has shown over and over, that it's at least as good, if not better, than fusion. And even if it's only as good, not better, theoretically and philosophically, it's got to be better because it's mobile where a disc is supposed to be mobile. It's not anti-physiologic like fusion is. So conceptually, it makes sense to me. And I think the more levels you do, the more it makes sense. So we know for sure that when you do a 4-level ACDF, only isolated anterior, you have a very high rate of it, a pseudoarthrosis of the bottom level, 1 or 2 levels, and an adjacent segment disease and increased neck pain. There's no question that your pseudo rates go up and revision rates go up when you do 3 and 4 level ACDFs. So it only makes sense that if you're going to do a 3-level treatment, 3-level disc replacement should be superior. And in fact, now there have been studies showing that, and I've seen it in my own patients anecdotally, where a 3-level cervical disc replacement in my hands is most typically an outpatient procedure, and I don't hold them back really any longer than I would a 1 or a 2-level in terms of their return to function and activity. So, and those people are not getting pseudos, and they're not getting adjacent level disease, and they're back to function and living life and happy with it. So it makes sense to me just from a philosophical standpoint. Now from a practical standpoint, I've seen it. And so I've pushed for that. And, a lot of times, as I said, it's frustrating because the insurance company's telling you just do a 3-level fusion, we'll cover that. That's not what the right thing is for the patient. That's not what I would want for myself, for my family. So that's not what I'm going to recommend.
So talk about that a little bit, because it's a fascinating topic to me that they push back on, a 3-level or 4-level arthroplasty. There wasn't a study that said 3-level fusion or 4-level fusion perform in a certain way, therefore we will reimburse them. Right? I think it's such a stark contrast, and I think it shows a lot of just the, forces that have pushed against motion, and reimbursement is a huge one of those, right? But why is that the case that, like you said, 3 and 4-level fusions get reimbursed, nobody asks questions, but if you go for 3 or 4-level arthroplasty, well, we don't have studies to support that. It's like we don't have studies in the past to support that.
I think a lot of it's baked into the ether, where it's, the insurance company policies are from 20 or 30 years ago, and they haven't been updated. And they have, reviewers that are, perhaps retired, that, no longer practicing, and this is the way they did it. And there's just not been an impetus to push against that. Part of the other hindrance is that, on the industry side, the FDA studies were done for 1 or 2 levels in the cervical spine. There's been no 3-level FDA studies done to get an FDA on-label indication. So for an insurance company, that's an easy, hard stop. It's not FDA approved, no go. So that's going to take some time to overcome that.
Do you think, we're in an interesting place where patient demand is, patients are getting louder and louder that they want alternatives. You have patients coming from all over the country to come see you because they know that you do motion preservation. You still have patients coming asking about getting Modus when you probably stopped enrolling over a year ago, right? And it's still a constant conversation for you. When do you think, do you see in the future where you get enough of that snowball rolling down the hill where you haven't, you go to insurance companies and you're like, how can you say no to this? This actually costs you less money if we do this. Do you think we're close to that kind of tipping point for motion to really be in the space? I know you said we're kind of at the infancy stage, but it feels like it's right there.
I think we're getting there. I mean, patient demand is growing. And as you said, patients are getting louder about it. Every time we submit these to insurance companies, I have the patients calling. I'm calling, doing peer reviews. I'm talking to anybody I can, to try and beat down the door. It's going to take a while, like I said. But the things that we can do to help ourselves is more data, more studies, more publications on multi-level surgeries and how they're doing. And then obviously on-label indications would be a big stretch. And I think eventually we'll get that. I mean, it may take some time for industry to do that, a 3-level cervical study, for example. But the other thing I think that is telling and is true is that the fusion is very expensive. And the insurance companies know that. I mean, the implants are expensive, the surgeries are expensive, and the repeat surgeries are expensive. The multiple repeat operations are expensive. The time off of work required to recover, all those things add up. And, the longer we do motion surgery and the more we can put out there demonstrating that not only is this less expensive on the front end, it's less expensive on the back end because you're not getting repeat surgeries. Once that becomes pretty well demonstrated in all the literature, I think it'll get there. It's a big rock to move.
Yeah. Luckily we got people like Siva out there.
Yeah, I was
talking about it too.
Right. Yeah. Siva and the work that he's doing and guys like him looking at health economics and cost effectiveness of surgery. And it's not only about how much does the implant cost that you put in at the front end. It's a whole array of factors that go into what was the total cost effectiveness of this intervention. And over the long term, I think motion preservation will win that argument.
We've talked about that a lot too, is just the data aggregation side and the following data and the sharing of data, because that's so important for pushing this forward. And I do want to preface too, I don't think that there isn't reimbursement for nefarious purposes, right? Like their role is to try and keep patients safe. So this is what we know for a long, long time, and it takes time, right? It takes time, and it takes a lot of work. And then you've got guys like Dr. Heelan Sivaganathan, and you've got guys like Jared Ament that are doing this health economics work. But the problem is, it's not a 2-year problem, right? It is a 5-year, and it's a 10-year journey that you're looking at. And so it takes time to publish on some of that, because if you look at it on a 2-year scale, sometimes there isn't differences, right? And I think that's something that is really important. We've talked about in the past as well.
Yeah. And I think we see big differences in the cervical spine over the longer term. I think in the lumbar spine, the differences are going to be even magnified because there's so many more forces spread across the lumbar spine. And so if you start to get into looking at 2 and 3 level lumbar fusions versus a 2 and 3 level lumbar modus, you're going to see some pretty stark differences, I think, in not only early results, but long-term outcomes in those patients. Reoperation rates should be starkly different, is my opinion.
How do you make this groundswell to get people over that hurdle? Obviously, a lot of it is outcomes data, but one thing I think you do a lot of as well, you speak at conferences. We've seen you on plenty podiums. You publish. Mm-hmm. Can you talk about the importance of clinical training and clinical education to push that forward? Not just on the patient side for what they should be looking for, but on the surgeon side as well. Because the truth of the matter is, a lot of this wasn't around when a lot of people trained, right?
Yeah, I mean, the importance of clinical experience is paramount. I mean, you can read about how to do motion surgery. You can talk about it. You can have focus groups and discussions and podcasts about it. But to really get good at it, you have to do it, and you have to do it a lot. And I think that's one of the hesitations for a lot of surgeons getting into motion is they may do a handful of cervical discs or lumbar discs, and they're, they didn't do so well. My fusion patients do better. I'm just going to go back and doing that. And it's got to be a commitment to, no, this is the path I'm going to go down, and there's going to be a learning curve. But you're going to have to commit to it and commit to getting good at it, or you won't. And until you get to that point, you're not going to really enjoy the benefits of it. It's like golf. You can't go and play once and expect to really be good at it. You have to decide, all right, I'm going to play golf now, and I'm going to get good at it. And you have to, struggle for, in many cases, 10 or more years before you can really, hit a decent shot. And, that's true in surgery too. It's repetition and experience, seeing multiple problems from different angles, working with multiple implants, multiple cervical disc implants, working with all the available lumbar motion preserving technology, and really beginning to understand what works, what doesn't work, why doesn't it work when it doesn't work, recognizing the patterns that are there. And there's no way to beat that except with experience.
It's so funny that you brought that. I was going to make a golf analogy, and then you beat me to it. So it's funny. I was at the U.S. Amateur the other day, and you watch these guys play. I mean, there's 15, 16-year-old kids out there and just lacing the ball. I mean, like straight down the middle. I mean, I've been playing for 25 years, and I can't keep a ball in a fairway, But it's funny because you can watch tour players, and all these guys play all day long. You can watch videos on how to change your swing. But if you're not playing all the time, it doesn't matter. And it's the same with surgery, right? Yeah. Like you can watch training videos, you can listen to talks and publications. They're all great, right? But you really have to get in there. And I think that's one piece that I see about motion preservation a lot as well, is you have to learn where things get implanted and when to use the right implant, right? So when you're looking at those first 2, 3, 4 surgeries, I mean, surgery is under a microscope like it never was before. If we looked at spine like we looked at knees and hips, like we wouldn't have knee replacements. We wouldn't have hip replacements.
Right.
Like there was this learning curve that we just accepted. But now it's like, oh, well, these 2, 3 cases, they were tough or they were challenging. Of course they were. Like you're learning how to do it. Right. And I think that's such a fascinating topic because you nailed it on the head of that. Like there's a learning curve at the start.
Well, not only that, it's you did things one way for a long time, or it's how you were taught. And then when you do motion, it's typically you have to like retrain or do it a new way.
It's a different way of thinking for sure. I mean, some of the mechanics are similar, the exposure and the decompression is similar, but the reconstruction is totally different in how you're thinking about soft tissue balancing and how much of the annulus do I need to preserve and how much disc height do I need to restore. And then thinking about how this is going to be moving. It's not just a fusion. So it's a totally different mindset with how you're treating that patient, and it does take some relearning.
Yeah, so you have to be committed to it.
Right.
Yeah.
So there's one more question that I have for you too. You've always been someone who's picked up the flag and pushed this forward. And I think sometimes you get a lot of arrows for that. I want to know what you're excited about in the future of spine. You've got a long career ahead of you, right? And so what does that look like? When you're watching on LinkedIn and you see all these things, you're starting to see hybrid cases. Now you're starting to see 4-level and 5-level cervicals. What is it that you're excited about that you're like, this is my flag and I can't wait to push it forward?
It's all the things we've been talking about, motion preservation and restoration. That is my game. That's what I'm interested in. That's what I'm focused on, because I think it's a great improvement over what we have. And the hope would be that it prevents people from needing big lumbar fusions down the road or dooming patients to a lifetime of multiple surgeries, and rather being able to restore them back to big mountain skiing or picking up their grandkids or whatever it is they want to do. I think this is a superior way to be able to treat most of the problems we see. And it's a great improvement over what we've had over the last decades. So that's exciting to me to be part of the kind of the forefront of that. And I'm going to plan to carry that on into my career and hopefully not look back.
Well, we love there are surgeons out there like you that are willing to do this work. And I think that comes from so many different aspects, right? I mean, you talked about your mentors that you worked with, and you talked about your experiences over time. And I think it takes time to train some of that and do those things. But for the people that are looking for you, that say, I want to have an appointment with Dr. Sielatycki, or I want to read about some of his material, where can people find you?
I want to go to a motion surgery center.
Yeah. So obviously our website, steamboatspine.com, you can go there. There's links to our phone numbers and appointment scheduling and all that. Have some information about all the different surgeries that we do. And I'm happy to, of course, see anybody that wants to see me and talk to me about motion options. There's a lot more people in this country and in this world than I can see. And so for anybody that, can't get here to Steamboat Springs, Colorado and see me as part of my practice here or any of my outreach locations, like for example, I go to Meeker, Colorado. I have some great people that help me out there. I would say, look in your local market, look for motion preserving options where you are. And if you can't find it, just keep widening your search. There are people out there and there's people doing it. So.
And if you aren't in Steamboat, this is a great place to come. You can't see it because we've kept you past dark, but it's a beautiful view.
It sure is.
It's not a bad place to get surgery.
We do welcome anybody. I have one patient from Tennessee, actually, 2 weeks coming out here for a 3-level disc replacement in his neck. So I think he's excited.
Well, we love the work that you're doing. We love that, you're willing to give back to, you're a guy that's very active on LinkedIn as well. So for people that aren't on there, I think you post a ton of super educational content on what motion looks like and how to pick out what questions to ask, what you should be looking for. But the truth of the matter is, right, this is a team, right? It comes from guys like that you've worked with in the past, Dr. Ahilan Sivaganesan. It comes from guys like Clint, who you were able to mentor with. It comes from guys like Dr. Scott Hodges, who you've worked very closely with. And then, you're fortunate that you've got an amazing wife back home who takes care of your 4 kids. And, Karen's amazing. We've been very lucky to get to meet her. But just everything that you do, we've been so fortunate to work with you and be part of this process. And we can't wait to see what's in the future.
Oh, I appreciate it so much. Thank you guys for coming. It's been awesome.
Absolutely. Thanks so much. We'll see you soon, Dr. Sielatycki.
Take care.